and welcome back to the White Noise Podcast. I'm Dr. Mohan Dutt. I got Dr. Jon Barkham with me. Our fellow cohort, Dr. Sachdeva, can't join us this week, so you'll see him back at the next episode. Today, we have Dr. Peter Farrehi joining us. He is a cardiologist at the University of Michigan, and we are very excited to speak to him today about the association between sleep apnea or sleep disorders and cardiovascular disease. So, Peter, thanks for joining us. We're really glad to have you here.
Great to be here. What an honor.
Thank you for coming in.
So, before we get started, as always, we like to start with our kind of get to know you questions. So, Peter, how did you get involved, or what's your interest in, as a cardiologist, how did you get interested in sleep medicine?
Yeah, so I spent my first 10 years after doing all my training in private practice. So I saw a lot of patients, and I found out that the most difficult cases that I had of, say, hypertension or arrhythmias or heart failure that didn't respond to my normal concoction of medicines or treatments or whatever, I couldn't control them until I diagnosed their occult sleep disordered breathing. And then once that was diagnosed and properly treated, then my routine concoction of medicines for hypertension or antiarrhythmics seemed to keep them in sinus rhythm or keep them out of heart failure. So I ended up, connecting with other practitioners that were interested in helping me identify my patients with sleep disordered breathing and treating them. And then I came back to the university about 10 years ago and recognized that, the space was sort of empty here within my division of cardiovascular medicine, and connected with my good colleagues in sleep medicine here. And the relationship just kept blossoming, and it's been great.
Yeah, we feel we're lucky. Obviously, you get to do a grand rounds lecture every year for our fellows that I know they appreciate, and even the faculty enjoy listening to. So it's great having you as a collaborator on a lot of the stuff that we are able to do. My next question for you is, what's the best piece of advice you've ever gotten? It doesn't have to be in training; could be in life in general, or.
Actually, it came just medically related. I remember one of the surgeons telling me to never fight over a case. And what that kind of has meant to me is if you give your best treatment to a patient and they walk away and you find out that they go to another doctor or they go to some other institution down the street or something like that for treatment, don't feel down on yourself. You just do the best you can, and the patient will end up probably back in your door at some point, and I've seen that happen. So yeah, you never fight over a case.
Sometimes they just need a different message from someone else.
Yeah. I think we get pretty bogged down in our opinions, the right opinion, and we don't want people to listen to anything other than what we say. But sometimes you need to get that alternative perspective, and sometimes we're not right. I mean, it's a humbling profession. We don't make the right diagnosis every time, but I think the harder you work and the more open-minded you are and the more accepting you are to see the patient back and really try to understand what their problem is, that makes you a better provider.
Sure.
I agree.
It's in this subspecialty too, even within sleep, there's some cases where I'm like, look, I'm at the end of my rope. I think you need to talk to somebody else, get a fresh perspective, even if we're not disagreeing, like we just hit like a wall with some therapies. Well,
in sleep medicine lends itself to that sort of multidisciplinary approach. I mean, I think the grand rounds that you all have is, one of the best examples of what we do at Michigan Medicine. This isn't really a plug for Michigan Medicine, but it's any sort of academic medical center. Sleep, combines, pulmonary medicine, neurology, psychiatry, psychology, otolaryngology.
It's got a strong,
I mean, it's a multidisciplinary. And then there's the whole pediatric versus adult.
right?
You know, I mean, it's a great field.
I think it's probably the only field that has so many different.
Yeah, we take them all.
I can't. You're exactly. I mean, there's you'd be pretty hard to.
The fellowship doesn't deny if you want to do a sleep fellowship. It's not like you couldn't do it. If you did surgery, you could do it. You know, there's just no.
I think you have to be. I don't know. Well, I mean, I don't know if you could do like general surgery and then sleep. Maybe you could. I have no idea.
I don't think they.
But
it was recent that the internal medicine side. I mean, you had to have finished your medicine within so many years before you could.
Maybe because I went straight from IM to sleep, and so did
I. Yeah,
so did you. So I'm not sure what the time gap is.
Yeah, there's or in order to sit for your sleep medicine boards, there was something that happened a few years ago.
I know you have to be board certified in medicine
first to take the
fellowship boards, but
that's right.
That might be it. And the last question is there anything, or it's our pick of the month. So do you got anything that you're particularly interested in, or, you know, movie, TV show, book, music, vacation, life thing that's outside of the medicine that you're just really, really into?
Yeah, for me, it's, I'm a audiophile. So I still listen to long playing records and have a turntable. And so I have a Doobie Brothers album that's high on heavy rotation right now. So
that's cool.
I'm a 60s and a 70s kid, and so I collect.
That's great.
It's a different subculture out there. People who go to record shows. I don't know if you've ever been to them, but we wouldn't wear our sort of our work clothes to a record.
My friend collects vinyl.
Oh, really?
Couple of them, yeah.
So you know what I'm talking about. Yeah, it's.
Do you really feel like
I've been to a show with him.
Quality is better compared to what?
Well, you have to have the right equipment and the right listening room and
distinguished taste.
Yeah. Well, I'm big on the home audio in terms, like you've been to my house and you've seen the movie theater type got built, but so I'm more into like the home theater. But my dad was big into vinyl, and he had the whole like Macintosh setup,
right?
And that's expensive.
But it's like the vintage, and that's hard to find records and rare tracks and stuff.
Well, and right now it's all about the 180 gram vinyl. They're reissuing it, and for Christmas, somebody sent me the reissued recordings of Johnny Cash and
that's pretty cool.
Bob Dylan from the late 60s and early 70s, and it is just incredible.
It's cool.
I love Blonde on Blonde. It's a great album. Highway 61 Revisited.
Oh, if you like that, you got to listen to Nashville Skyline and Johnny Cash. It's
Even though
don't get me talking about that. We'll be here for 45 minutes.
No, it's cool.
I was born in the 80s, but I love Zeppelin, and I love a huge, love 60s and 70s.
Too bad we can't do this podcast in my house.
Background music. What's your pick of the month, Mohan? I have to go first.
Yeah.
I've been, my girls and I, like family entertainment, we've been watching Little House on the Prairie on Amazon, and the kids love it. Yeah, well, they have it on Prime. I mean, it's free on Prime or whatever. So I think we've watched like tons of it. So
is that the one with Michael London?
Yeah, it's like very wholesome, and the kids love it. And
what age is other girls?
7 and 9.
Yeah, perfect.
It is. Yeah, so they identify the characters, and they want me to build the Little House on the Prairie house in the backyard. And
I don't remember that. I mean, I remember watching it.
It was a little bit before our time, you know, because it wasn't on network TV much in the 80s.
It was on like syndication.
Yeah, but it's good, and
it really tests your cry gene, doesn't it?
I'm not going to admit it, but it does.
I would cry at the end of every episode.
There are some tearjerkers.
Yeah.
Yeah, there definitely are. So.
All right. My pick of the month. We've been watching a couple of things. A couple of Stephen King books that have been made into TV shows. One's on HBO currently. It's called The Outsider. It's phenomenal. It's based on the book called The Outsider. It's really good. It's got Ben Mendelsohn, who was the villain in Star Trek Rogue One, and also has Jason Bateman, who's kind of awesome in everything that he does. And then the other set is called Mr. Mercedes, which is based off a trilogy of book called Mr. Mercedes, or the Bill Hodges trilogy.
See, I was going to guess you had watched The Stand because of the coronavirus coming out.
Oh, that's a great book.
I read it.
It's a phenomenal book.
You read The Stand too?
The TV
Oh,
series
God.
with Gary Sinise, not so much, but they're remaking it.
Yeah, I read it during residency while I was on call.
Yeah. I actually audiobooked it on my commute.
Now more than ever.
Yeah,
The
I actually
Stand
thought about that too. Yeah,
terrifying.
It's pretty terrifying. But his Stephen King stuff is really interesting because it's all connected in some metaverse.
Yes.
Of like different. So even though they're different stories, there's some loose connection.
If you like that, then you'd like The Gunslinger.
Oh, I'm reading that.
Oh, you are?
I read up to 5 books of the Dark Tower.
Oh, okay. Then I'm preaching to the converted here.
Yeah.
When do you have time to read?
I audiobook a lot.
Oh, do you? On the way in?
Because I'm in Brighton. So it's like 35, 40 minutes in the morning each way.
Yeah.
So I audiobook double speed.
Double speed.
Double speed
Crush
audiobook.
book
I have to be super efficient.
Yeah.
So I get like 2 hours of a book in each way. So I get 4 hours of listening.
Wow.
in.
Yeah.
And so even like The Stand was like a 40-hour book on audiobook, but
2 weeks?
About 2 weeks.
Wow.
Yeah. So let's get on. So usually, as you guys know, we usually do a case, but I think we're going to just kind of skip the case because we're going to be kind of focusing on more cardiology stuff. So we're going to just assume that our patient has obstructive sleep apnea, and he came in, he had his polysomnogram, and we're going to talk kind of about the EKG stuff. And I guess the first question I have for you is what should we be, or what, other than arrhythmias, or what arrhythmias, what EKG findings on what can we get on a 2-lead, EKG that would say, hey, maybe this person needs further cardiological evaluation.
May I back the train up?
Yeah.
I never even look at EKGs anymore when I do an evaluation for a patient. It's like I check for an echo, I check PFTs, I look at past medical history.
Yeah.
I never pull up an EKG. Should I be doing that?
Yeah, I mean, I was going to ask you guys that exactly. Is you'll read 10, 20 studies in a row or whatever, and I mean, do you open up the chart and look at the not just the reason why the doc sent him in, like excessive daytime sleepiness or snoring or hypertension or what, or do you, I mean, if they come from a cardiologist, it
usually says in my consults why they're coming in. I kind of look at the service, but like what I'm saying is like, I don't, as like my pre-op or my, when I'm doing the chart review, I never pull up an EKG almost ever.
Yeah. I don't blame you for that. I would look for the note. I mean, I would look the note from the provider and, well, I have a question for you. Wouldn't you rather, or maybe I'm assuming this, wouldn't you rather see the patient first and then do the polysomnogram, or do you just see the patient, or is this a
no, it's a good question.
It's a good question.
Especially now I'm not, and
depends.
And it depends. So say
depends on who's paying, right? Because if it's the insurance companies, I work in a different field, so I'm at the VA. So I could probably do a chart review, get a home sleep test, and
know what
to do with it. Because getting a home sleep test on somebody, the diagnostic part isn't the problem; it's what you do with it. Because you can't autopap someone with heart failure, per se, right?
Right.
So then you have you do a high quality level titration,
right?
Because you've already kind of been through it, unless you're super suspicious for central sleep apnea or other things. So, yeah, some of my we're working on maybe what they call first virtual consult at the VA, where I just look at the chart, and because we're so understaffed that we might have to
screen them that way.
Yeah,
I would figure that. Let's say, for instance, if I'm sending a patient and I'm pretty sure they have obstructive sleep apnea. I don't know whether or not they may have a combination of central and obstructive. And actually, I've picked up a couple very strange REM disordered sleep disordered breathing. And those were in a couple thin people who had lone atrial fib and no other explanation for it. They didn't look like they had obstructive sleep apnea, and they didn't have any of the physique or any of the risks, but then they ended up having REM disorder.
REM predominant. Yeah. Sleep apnea. Yeah. That happens a lot, actually.
So, no, I mean, not in my practice, but
I see it in mine, but I mean, I'm not saying it's like, oh, heart failure, REM predominant, but
in that situation, I would rather them be evaluated by a sleep medicine expert, have them then schedule the polysomnogram and do it that way.
This leads to another question that I wanted to ask you.
But let's come back to the arrhythmia too. So
I guess
let's finish the question. I guess right.
Well,
should I be looking at the EKG?
Well, that was an initial question, but do you feel like, and we can kind of get into the arrhythmia stuff afterwards. So patients who have AFib or heart failure or arrhythmia, like that you see in clinic,
or resistant hypertension, common.
Should every patient with AFib get studied? Or, in your opinion, I don't there's no data on it, but there's a pretty big correlation between AFib and sleep apnea. And I think in the sleep literature, it's almost up to like 70% ish, maybe. So, I mean, do you feel like if it's, they've failed a cardioversion once or they failed ablation, that kind of leads them at that point?
Right. Two scenarios. One, the easy one is like what you said. If they look and have all the risks for sleep apnea and they have AFib, they certainly need to be studied. Forget about the AFib. You
could do the stop bang.
Right.
Right out of the gates.
Well, most of the patients that it's like,
so the risks, so the obesity and the age are the two biggest risks for both sleep apnea and AFib. So, you can, and then you throw in if you're a man, so then your stop bang right there.
I would say 40% of our population that we see is obese, over the age of 50, obese, and male.
And has hypertension, so they get a P,
so that's 4 points. That's already 4 points.
That's 4.
That's 4 points.
And you didn't bother with the neck size.
The more interesting, the more challenging, dilemma is the lone AFib, the sort of 50-year-old who, is in otherwise good shape. I don't know if they have a genetic tendency. We don't have a gene for AFib, but I think in the future we're going to have genetic tendencies.
That'll be interesting.
And the other unique population that I stumbled on in my practice, and now I still see it as well, and I'm sure you do. Anybody who develops a nocturnal arrhythmia that's sustained. So the patient who, they have their first episode of AFib and they're in the ER at 6 a.m. because they feel lousy and they can't go to work, or they try to go to work and they're in rapid AFib and they can't stand it. They go down to the ER, first diagnosis of AFib that starts in the middle of the morning. That person needs a sleep study.
Right.
Regardless of their physique, regardless of their stop bang, regardless if they snore or not.
It makes sense. I mean, the sleep is arrhythmogenic, and if they woke up with an arrhythmia, we should check their sleep.
Exactly.
So,
and it could, they could have hypoxia. They could have REM disorder. I have 2 of them like that.
Yeah.
Just my small panel.
Yeah. With the AFib, as far as, the screening guidelines, it's kind of gray because you don't have to, there's no thing that says you can't do autopap, right? In someone who's got arrhythmia. It's not clear.
The treatment is,
you're just concerned that they're going to develop central, or at least I am.
Treatment emergent
central sleep apnea because it predisposes.
So
what, the treatment of obstructive CPAP, regular CPAP can increase your risk of developing central?
Oh, absolutely.
No. Well, I mean, in the sense of, it's assumed that since there's an arrhythmia, that there's some sort of cardiovascular problem and that you could have a higher risk for treatment emergent central sleep apnea. But this is a gray area because they never said you had to do level 1s for arrhythmias. So I've been doing HSATs and autopap. And if there's a problem, then I titrate.
Right.
As long as there's no heart failure. But it's this gray area because some people in this practice will do level 1. You have AFib, level 1, but there's a time delay there, right? Because sometimes we'll get patients that they're going to be ablated next week. right?
Right.
And you kind of know that I think the data is the first 60 days after an ablation is the most common time for them to relapse. And it's like, well, we got to get you tested and treated and like now, like yesterday.
So you can't do a split study in those?
You can, but like for certain labs, you may be booking out a month.
Right.
Yeah. I mean, I personally, if someone comes in, now this is all insurance dependent.
Yeah.
If someone comes in with AFib, I'm more prone to try to get them in the lab to do a study rather than autopap them. Because my concern is that if I were to autopap them and then not have close follow-up, they're going to go into, they're at greater risk for having central sleep apnea.
Yeah.
Once you start them on PAP therapy, by bringing them into the lab for the titration, you can at least see if it's going to develop or not.
You're not wrong. I'm not saying you're wrong. It's more of like an acuity and access issue.
Right. Absolutely.
Right. So you can get away with the HST out of pop combo if that's what's quickest and most convenient for the veteran, or I mean for the patient. But if you're also in private sector and you've got good access, get them in, get them done. I don't disagree with that.
What is LV function? Do you look at the echo and see if their LV function's down?
You got to do level 1.
Yeah. I mean, heart failure, that's
systolic dysfunction.
Right. Systolic dysfunction, ejection fraction.
What about, and then the gray zone has got to be heart failure preserved EF.
Right.
Yes.
Yeah. So
you're right.
There is the guideline. It's hard.
And we could march in, 20 other doctors in here and you'll get 20 different opinions about.
Right. I mean, anyone,
That's correct.
on a long enough timeline, anyone's going to get heart failure with preserved ejection. Anyone with hypertension probably is going to end up with, because all the echoes you see say grade 1 diastolic dysfunction,
Yes.
and it's completely normal. They all technically have heart failure, but it's just mild. So
the classes of heart failure, but they had to dumb it down because this is such a multidisciplinary practice that it's like, what's the ejection fraction?
Yeah.
Okay.
Yeah.
At least we have like a gold, somewhat of a standard,
So what in the arrhythmia, I guess, because not everyone here is, I think, going to be a sleep practitioner or might have studied this. Why does sleep disordered breathing predispose you to atrial fibrillation, or what's kind of the basic pathophysiology behind what is going on?
So I think you guys probably know this better than me, but I think the leading hypothesis right now is the structural and electrical changes, the negative inspiratory forces that occur with an obstructed airway lead to some structural changes of both the atrium and the ventricle. But in this case, the atrium seemed to be irritated more. And then with obstruction and hypoxia, this seems to stimulate some of the chemoreceptors that then stimulate the autonomic nervous system. And, one pathway some think is more strongly associated with the sympathetic nervous system. So it can lead to
adrenaline release after.
And it raises blood pressure. And then the blood pressure has hemodynamic effects on the heart as well. So it's, and I can really relate to that. I think it's follows a logical, common sense, mechanistic cause for atrial fibrillation.
Well, hypoxia itself, it makes it unstable, right?
It's we even see it in the cardiac catheterization laboratory in some big infarctions that some of them come in AFib from ischemia. But I don't think our routine sleep apnea patients are getting ischemic. I don't want to say that by any sense, but hypoxia is a really potent stimulator of inflammation, hypertension,
and it's really that chronic intermittent hypoxemia that we see in sleep apnea patients rather than like someone who lives in altitude, because they adjust appropriately.
Right.
It's that.
Right.
Intermittent hypoxemia.
There's a bit of a, what I've seen with my patients that have flipped into AFib during the sleep study is that there's a bit of like what they call a dive reflex, or there's this bradycardia.
That's right.
And then there's like this sympathetic discharge with a tachycardia afterwards. And then you see the AFib. Mm-hmm. I mean, I see it like once a year at night. It's like, oh, hey, he flipped an AFib.
Yeah.
Yeah. And
so it turns out that there are some antiarrhythmic drugs that are better that have anticholinergic properties that I sometimes use in those nocturnal stimulated AFibs.
What are some examples?
Disopyramide has anticholinergic properties.
Hold on while I get my textbook.
Yeah, I know. Yeah. That is a cardiologist drug.
Yeah, exactly. Do not try this at home.
Take
on your
me
own.
back to boards.
Yeah, exactly.
Yeah.
No, it's a 1A agent.
Okay.
Similar to quinidine, but nobody uses quinidine anymore. But
this is really racking my brain now.
So you found that this is more effective when you say nocturnal onset, you mean like I diagnosed it on the sleep study, or you did like a 24-hour monitor?
No, I take a history of the patient.
Okay.
Yeah, and patients who have these are symptomatic atrial fib patients. There are a lot of people that have asymptomatic atrial fibrillation, and those are the ones that we don't rhythm control, we rate control them, meaning we don't try to cardiovert them. The kind of person that comes in for their healthcare maintenance exam, 62-year-old, hypertensive, diabetic, obese, sedentary, comes in for his routine physical, and his intake vitals are irregular. You get an AFib. Guy had no idea he was an AFib.
Yeah.
And that's an asymptomatic. I call that's a different population that I see and I treat. But the person that I'm more likely to really drill down for the triggers of AFib, because then I like to tailor my treatment.
I see.
Of the AFib is if they can tell me that comes on, I may go out for dinner with my wife on a Friday. We have, a full bottle of wine, and then I wake up feeling lousy, and then a couple times this happens, and then they're in AFib in the morning. So alcohol may be a trigger, and alcohol is definitely a trigger for poor sleep. Mm-hmm. So if you really take a history of people with AFib, many times, more often than not, you can figure out what the trigger is.
They know. Yeah.
And maybe the first time they don't figure it out, but if they're symptomatic with their AFib, they want to figure out what caused it and they want to prevent it. Mm-hmm. So if you can tailor the antiarrhythmic drug for them, because a lot of my patients don't want to go for ablation as the first treatment. And they want to say, gee, isn't this the most commonly treated arrhythmia in the world? Don't we have some medicines for that?
Is I guess why, I mean, when I was, this is not that long ago, when I was in residency, I was, rate control is not inferior to rhythm control. So that's still, even in patients who are symptomatic, I feel like, because it was always like, you never know if someone comes to the ER and they're symptomatic, and is this really their first episode of AFib? So it was, you never know if you really should cardiovert them or not, because what if there's a thrombus hiding in the, in the atria or whatever? So I feel like we never actually.
But if they're hypotensive.
Right. The only time we ever cardioverted was if they were hypotensive.
And how many of those stroked?
0. Yeah. 0. We did in the ICU all the time.
Right.
But
they'd be on pressors, and we're just like, all right, let's just cardiovert them. And then, no one's stroked out.
Right.
I always felt like the attitude, and I haven't done this in a long time, but was like, well, everyone deserves a shot at normal rate, and then if they fail, they're like, well, we can rhythm control. Yeah. I mean, I'm sorry, shot at normal rhythm. We can rate control if we couldn't, convert them.
And that's still the practice, John.
Okay.
Like going back to the guy I just said, the 62-year-old shows up for his healthcare maintenance exam, incidental AFibs, just found. They'll get sent to me or, another cardiologist just to kind of manage it. Mm-hmm. And, I'll explain to them the risks, benefits, and alternatives to rhythm and rate control. And my general approach is to try to get them out of it. Well, at least once,
Right.
and a good number of them feel better. Like they didn't know.
Right.
Like
Yeah.
it was sort of an insidious thing.
It's like the asymptomatic OSA patient.
Yeah.
Like, I don't feel bad, but you put me on treatment. Oh yeah, actually I do feel better. I didn't
Exactly.
realize
I don't fall asleep, or I don't have to go to the candy machine at 4:00 in the afternoon every day to get some glucose. You know, I'm awake at 4 PM like I was at 10 in the morning.
That's why it's helpful to have those intake questionnaires where you're like, well, you were this fatigued or this.
That's right.
I check fatigue and daytime sleepiness.
Yeah.
2 different measures. Be like, well, actually,
Yeah.
because I get that. They're using it. Like, for example, they'll be using their CPAP and they're like, but I don't feel any benefit. And they're like,
How do you assess their concentration before and after? Or besides what you just asked?
well, concentration is difficult because you'd have to measure psychomotor vigilance.
Right.
And that's a little more involved.
Yeah.
But I use the Epworth Sleepiness Scale and the fatigue severity.
Yeah. I just kind of
Index.
ask them, like, do you feel like you're having issues with concentration at work specifically?
Mm-hmm.
Do you have trouble? Do you have trouble focusing? Do you have, is your work performance decreased? But yeah, as John said, I mean, psychomotor vigilance is definitely, that's like task performing.
Yeah.
Repetitive, like
Essentially, it's like a red dot shows up on a screen and they measure your reaction time on a space bar or something. And so it's supposed to be well validated.
Really?
Yeah.
And they do it in studies for treatment and to see if you get, improvement in latency, I guess.
It's not how many addition and subtraction, equations can you do, or
it's visual. I'm sure that would be a study too.
Yeah.
But for the psychomotor vigilance, it's like random like task, like motor visual.
I think it's
skills.
developed by Walter Reed Medical Center, or some of the experts. But
awesome.
I believe you can get a version of it
You probably could, yeah.
for research.
Yeah.
Because I wanted to integrate it into my intakes. But
Good luck.
yeah, and the VA firewall is something else, I'll tell you. But
what other arrhythmias?
So non-sustained ventricular tachycardia has to be up there. Ventricular tach is a scary.
Could you please, as a
arrhythmia.
cardiologist, tell us what non-sustained ventricular tachycardia is versus VTAC? So what's the difference between what does non-sustained mean?
Oh, well,
and when do you start getting worried?
So non-sustained ventricular tachycardia by definition is, I think, 3 or more consecutive PVCs in a row. And, unfortunately that is, I didn't make that up. You didn't, and I'm not going to change it. Sustained ventricular tachycardia is ventricular tachycardia that lasts more than 30 seconds.
Right?
Sustained ventricular tachycardia is long enough that, people are not going to, they drop their blood pressure. They don't look good. You probably hit the code button. You probably send the person down to the emergency room.
if they're awake.
If they're
awake and they're sleeping through it.
Well, that's the problem is that we get these phone calls at night and they're like, they had 5 beats of, and they're and we're like, okay, well, they have sleep apnea. So,
right. Now that's the other important feature of the arrhythmia is what associated, episode was occurring while they're sleeping. Is their oxygen level down to 85%? Is it down to 69%? What's the lowest O2 sat you guys have seen on a sleep study? Like less than 60, right?
It gets so low sometimes. I'm like, I don't think it's accurate.
Right. Yeah, there's always
57%.
I've seen in the high 50s.
Yeah.
But then you always question the pleth.
Yeah.
And it's hard.
So what you're saying is it's in context of what's going on.
Yeah. And if they've had a 15-second apnea, well,
surprise, right? You're not surprised.
I'm not surprised.
Yeah.
And tell me a little bit about the patient. Oh, he's 70. He's had his bypass, or his EF is 40%, or he's on. Give me a list of his all you'd have to do is ask what medicines is he's on, and you're like, you know what this guy is. He's a walking heart attack, right? As they would say on the street.
I think the biggest annoyance of any fellow who's in sleep medicine is the AM page at 4 a.m. for 3 beats of or
Yeah.
for NSVT.
Right. Thank you very much.
Yeah. Yeah.
The best ones, there'll be a sleep still.
Yeah. That's
And,
it. Yeah.
and they'll have like, something more like 15 beats. And you're like, but they're asleep. I mean,
So you don't, and another thing is we're not measuring blood pressure. So you don't really know what else is going on. And so,
Yeah,
there's-
So then what should we do with those patients afterwards? And we have this discussion every session.
Right.
That I come.
So what?
Well, I mean, I think,
No.
I think communication is the key, number one, right? I mean, it has to be reported on the report.
Right.
And I think if the patient has a cardiologist, the cardiologist should be notified. And if they don't, the person who ordered the test should be notified. If it's a sleep medicine person and they don't already have a cardiologist, they come to my office. I mean, you refer them to me and I see them. I think what the group here has been doing lately, and I think is really helpful, is to get a Holter monitor, between the sleep study and just to kind of see.
Is that something that you are, or that you've seen sleep medicine order?
Yeah.
Yeah. That's actually a good idea.
And because then the test is back by the time I see them, and I have more data. And if they don't have an assessment of their LV function, because non-sustained VTAC with a low EF, we think of a little bit differently than non-sustained VT with a normal EF, and then of course syncope. But these are historical and structural details that need to be hammered out in a consultation.
But it makes sense. Get a Holter, notify the primary or the cardiologist, and get an echo if it's not already been done.
Right.
And
an EKG, John.
Jeez,
that John's not going to look at.
Well,
we don't have those in sleep clinic.
They don't do EKGs at the VA.
Okay, I will say I do occasionally look at an EKG.
Occasionally,
in the sense of like, do I have to notify like my overnight texts? Because if they
don't have an EKG on the chart, they just need to have it before they see me or a cardiologist.
I love EKGs,
but in the sense of,
as a resident, I picked up S1Q3T3 once
for a PE.
And it was right.
Yeah.
And I picked up Brugada once.
Incredible.
So now I just look good because of it.
So you look now with your...
I look at... Yeah, I think not for every patient.
It's probably...
If there's anything abnormal on the EKG, on the sleep study, I will double check to make sure that it's not something that they already have.
So there's one other thing too, Mohan. Mm-hmm. Long QT changes their management, So I mean, it's a great tool. It's cheap.
Yeah, it's already there usually for us.
Yeah.
I do look in the sense of if my techs have someone who's got chronic AFib, even if it's been chronic, they will call.
Right.
Like this patient's in AFib. It's like, yeah, I know.
Yeah.
So, it's one of those, occasionally I do look and to see if I'm getting them from cardiology to see if they're still in AFib or where things are.
I have another question for you. This is another arrhythmia question.
I was going to say the AFib. I thought you were going to talk about the AFib with pauses in the older person, but we got
that too. Sinus pause, 3.2 seconds.
Yeah,
but it's AFib.
That's a whole nother discussion.
No, but that's part of like these phone calls we get, and it's kind of like, I'm in the middle of a diagnostic study. Put some CPAP on them, and let's look at it. Let's do the Holter in 4 weeks after they've used their CPAP. Yep. That's kind of, I've also done that where it's like, yeah, it's arrhythmogenic.
I think that's the proper treatment.
Or would you do, next week when they're still not even set up, do another Holter? Like I'm always like, when do I get this Holter monitor?
So 6 months ago, I saw a guy in the ER. I was on consults, and the guy looked Pickwickian. Okay, like you could, and he was cyanotic and clubbed. He was a 62-year-old farmer from one of the neighboring towns out here. Had not seen a doctor probably since his Army physical. Okay.
They're out there, these people.
Oh, yeah.
It's amazing.
Still smokes, all this kind of stuff. And was short of breath. And his sister brought him in. He was never married. So his sister brings him in. And he's in the ER, short of breath. They wanted to admit him, for heart failure or whatever. And on the monitor, he's wanky-bocky. And the ER is going nuts. They're calling me to put a pacemaker in him. I'm like... this guy just showed up, he's got 14 problems. We better treat that.
Yeah.
But sure enough, he continued to have significant heart block. but not Mobitz 2. He just had Mobitz 1. And the guy was narcoleptic. Like, he's sitting there talking to him and he's like falling asleep. I mean, the guy is ringing the bell. He has every risk for, sleep disordered breathing. And I still follow him to this day. He didn't put a pacemaker in him, just got his sleep apnea. I got him to quit smoking, got him to lose some weight, control his blood pressure. He doesn't need a pacemaker. He just needs CPAP and medical treatment.
Right. So the question I was going to ask you was actually about Wenckebach or Mobitz 1 versus, or even type 1 heart block. Oftentimes I'll read these studies and there's notes saying patient goes in and out of type 1 heart block. The patient goes in and out of Mobitz 1. Is that a thing? I thought if you have heart block, you have heart block. Or like if you have do you flip in and out of, is that a thing?
For the second degrees, yes.
Okay. So
but if you have first degree AV block, you typically
just have it, right?
Have it.
Okay. That's what I thought.
And then you can have long first degree AV block and then episodes of second degree. It's complicated, but clearly one of the risks would be hypoxia. I mean, if you're apneic and hypoxic, I mean, one of the most sensitive tissues, are the SA node and the AV node.
I mean, that PR interval, I feel like I've seen multiple studies where I've got notified and I'm like, this is changing here. Yeah. And it wasn't there and then it is. And it's not Wenckebach, but it's changing throughout the study with the sleep apnea.
I feel like it's hard for me to call, like, if I don't see it consistently, I find like I wouldn't make a diagnosis of like, I'm like, there is something going on here, but
I kind of just say like possible.
Yeah, some arrhythmia, kind of go through them. NOS, like,
and then I kind of go through the motion.
Refer to cardiology,
order a Holter,
and get an EKG.
So that's right, John. One other in the differential for that, when you see that, and is very difficult to tell on only 2 lead EKG that you guys see during a sleep study, are intermittent premature contractions, because the premature contraction may have a different PR interval than the normal sinus beat. But you may not, so the configuration of the P wave may be different, but you may not.
Because on a 2 lead, you can't really make
you that. May not be able to see that much different.
I've seen diagnoses of, multifocal atrial tachycardia or wandering atrial pacemaker, which is just the slow form of MAT.
But you need a 12 lead.
Right. And that's what I'm saying. I was like, we do these things and I'm like, you can't make that call on a 12 lead, or even like ST depressed. I've had people like saying, oh, the ST, ST's depressed. I'm like, you need 3 contiguous leads for it to be
correct.
For it to be clinically significant. So,
how much do you think the position of the patient,
or even the position of where the leads are placed on the patient?
The leads are number one. But when the patient is moving while they sleep, suppose they sleep on their side, or do you check to make sure that they're mainly sleeping on their back, or?
Well,
we encourage supine sleep
because of Medicare criteria. If you don't get the numbers, then you can't get them in the machine.
It's always an interesting conundrum, because what if the patient really just sleeps on their side at home? Yeah. But then they come into the lab and you're like, well, you have to sleep on their back.
Yeah.
And so then they get this diagnosis of, well, maybe you don't really. That's when kind of positional therapy comes into play. But I think we want to get the diagnosis first, and then we can try to figure out what's going on.
I think we try to, I don't have to play those games at the VA, so I get to treat more clinically, and it's more of, we see both positions. So if they've got purely supine sleep apnea, I luckily can we can treat it. Well, let's just say if they don't meet Medicare criteria, I can still treat it. It's all clinically based. So, positional therapy is an approach I sometimes have to take just for some of the issues we have at the VA.
And what do you use as positional therapy while you're doing this? Do you just use pillows? Or
they make a few devices, but
I know.
The Zoma pillow, most of the people hate. It's this pillow that wraps around.
2 pillows. There's the Zoma pillow. There's the Slumber Bug.
A lot of veterans sleep with no shirt, so they don't want this. nylon pillow around their waist.
There's a new device, not a
What
plug.
about just a Nerf football?
Well,
Yeah,
Some people take a fanny pack, put tennis balls in it, sew it up.
Yeah.
Yeah.
That's,
There's the Night Balance. I don't know if you've seen this.
I think
one.
it goes around your neck, though, doesn't it?
No, it just it's like it goes around your chest. It's like a little thing. I think it's Philips Respironics that does it, and basically it's like a sleep trainer. I haven't used it yet, so this is not a plug for them.
No.
But it seems pretty cool. You wrap it around your chest, and then basically whenever you are supine, it will send like vibrations to kind of have you adjust your sleep. So it'll keep vibrating until you move over onto your side, and then it stops.
Which I always thought was like, but if they're on their back, they snore. So they're already waking up. So we're just trading one disturbance for the other.
Right, but they're not rolling over unless they're white or unless their spouse is punching them.
Right, but here's the thing: if you're snoring so badly that you're choking yourself
and you're waking up,
like how is that less? How is that than this thing vibrating on your chest? You know what I'm saying? Like what's a more, I would suspect that choking yourself awake would be more of a indicator to stay off your back than a vibrating egg in my stomach,
But they don't.
Yeah, I guess
right?
that's the thing is they don't.
Yeah, I haven't tried out the Night Balance.
I haven't either.
It's one of those more like I'm a bit skeptic because it's like one more gadget to fix your life, sort of deal.
Bionic man.
But I end up just telling patients wedge pillows. I get They do use wedge pillows. I get them upright a little bit. Those actually have more buy-in than the Zoma pillow.
And positional therapy that I've seen effective in my patients is really just with mild sleep apnea.
Mm-hmm.
It's not really a good treatment for severe.
I mean, I would.
You're not wrong. In certain cases, I guess it's like, upright side. But
there are some patients who have just rip-roaring sleep apnea only on their back.
Right.
And then, you'll just see these clear-cut periods of sleep apnea that correspond with.
I mean,
I typically, but positional therapy for me is more of, in the sense that we can get everybody a CPAP, where I'm at. So it's not like, you don't qualify for one.
Yeah.
It's usually you qualify for one. It's that they can't tolerate it.
Right.
And so we use it's one of many options I get to employ.
That's
but
what
usually like with some, we're talking originally about doing like this virtual, how do I manage patients virtually and stuff? It's like, with part of getting people to use a CPAP machine is that salesmanship of like, this is why you want to use it because you've got AFib and heart failure, and this is the reasons X, Y, and Z. And you lose that salesmanship if you've never met the patient,
right?
And it's just coming through primary care, and they're like, you got AFib. We think it's sleep apnea. Yeah. Get a study. Go on the CPAP the rest of your life. Well, that you don't get that education piece, and so that is a problem that we'll have to deal with as more of this gets rolled out. And it's probably happening in the private sector too, because you're getting more primaries already in home sleep testing and so forth, and not getting that message. But I don't know.
I don't order many home sleep tests because most of my patients are complex.
Yeah,
and so I am more likely to just send them to sleep medicine.
You directly consult them.
Because and
it makes sense from specialist to specialist,
from me and I they ring the bell with a stop bang, or they have really difficult to control hypertension, or.
But so what to you? I guess for you, what is different? Like what's difficult to control? Like, is it X amount of three medications or more? Okay.
The definition of resistant hypertension is 3 or more antihypertensives, and one of them must include a diuretic.
Okay. But should we automatically just be screening patients who come through with AFib? Like, hey, here's your stop bang. You scored.
That was my initial.
Yeah.
I mean, our group here is pretty aggressive.
They are. I have gotten
our group here is pretty aggressive, and it's not just our electrophysiologists. I guess it depends on which cardiologist you're seeing, but by and large, I mean the news is out.
But is it like stop bang? It's 3 and above. You're going straight for level 1, or is it sleep consult first?
I think most of us are just sending them sleep consults.
I get a lot of consults from
from me or the
other
cardiologist.
I know who it is, but just based on the referral.
Yeah, exactly.
It's cardiology center.
Yeah, and then you just look at their medicines or you look at their procedures. And
so, I mean, the two big ones are, and I've gotten a couple resistant hypertensions, but it's AFib, heart failure, and and resistant hypertension.
And it's just, it's really, this is, one of my take home points, for everyone listening is, one of the difficulties we have is the studies that are done with CPAP. The compliance with it in clinical trials is really not that great either. So, I think CPAP works, and I think it helps reduce cardiovascular events. That's just my
right.
I have a bias, but the clinical trials suggest that maybe CPAP therapy reduces events. There's no effect on. We can't have any conclusive effects on cardiovascular mortality. I recognize that, but a part of it is the lack of compliance with CPAP, even in the clinical trials. So it reduces the.
I think the data out of
conclusion.
The Sleep Heart Health study was exciting in that there was some, and then the JAMA article came out 2 years ago now, was it? That just said that there was no benefit. It was in JAMA, but there was a meta review, and you're right. The studies that they chose, there was 11 studies that they chose to review in this meta review.
Yeah.
From Spain and all over.
Right.
The compliance was 3 hours, so they're taking non-compliant patients. And then they weren't really taking, they weren't even taking severely, they were taking asymptomatic, they were comparing them to asymptomatic. It was weird. But the big thing I did get from that was these studies were not, the ones that they chose to use to make this determination that CPAP was not effective were not very good studies.
Right.
And they were not they were not what we do in clinical practice.
Right. But I think it'll just take time. It's akin to the cholesterol story with coronary disease. There were a lot of practitioners that were convinced, they had a bias that by lowering cholesterol they were going to reduce coronary events. But for years they didn't have anything until the 4S trial. And I just think sleep disorder breathing and cardiovascular disease are so common, and it's now really on the forefront of many practitioners.
Let me give you a hypothetical. I've got a patient has a funny arrhythmia on the diagnostic. I'm like, hey, let's put him some CPAP. How quickly do you think I should expect those arrhythmias maybe to improve?
That's you mentioned it yourself, probably a couple weeks, 2 to 4 weeks. I guess it depends on how severe it is too.
Yeah.
Like the guy that was in the hospital that I said that I wasn't going to put a pacemaker in. I just wanted to, I took all the weight on my shoulder. Like if the guy passed out and had heart block, it was all on me because I laid down in front of him and I didn't let anybody put a pacemaker on him until his sleep disorder breathing was treated. So I, if you have severe and you get treated, you'll see, improvement.
So there's no set time.
You have to assume that arrhythmia is secondary too, because you could also have an arrhythmia that's not secondary.
Yeah, that's
just due to your obesity, due to your untreated hypertension.
Right. Lots of things, right?
There are so many intermediaries.
I think that's why this becomes muddied in general, because they have poor protoplasm, right? I mean, you're talking about obese patients with hypertension. They have, intermittent hypoxemia from sleep apnea, possibly heart failure, And so I guess whenever I see someone like this, I always try to, they're fatigued. I'll say, there's a lot of reasons you could be fatigued. It could be from your arrhythmia. It could be from your heart failure.
Fragmented sleep.
It could be from, you get up there, it's like, by treating your sleep apnea, I'm taking out one piece of the pie.
Right.
And that's what we can do.
Right.
It's just, there's everything is so interconnected.
But for another example, for surgical I used to do pre-op consults, and we used to have people try to quit smoking. I think, was it 6 or 8 weeks before their surgery, right?
Even just a few days now is beneficial.
Yeah, but there's some sort of time, and I don't remember the exact time, but to have it out of your system. And then it's I see people for AFib, and it's almost like a side thing. It's it's not that, we should, have the sleep apnea treated for a month before we cardiovert. It's when you get to treat it, we're cardioverting, and should it be treated more like the smoking cessation thing? Like, hey, look, we want to do this one time. So treat the sleep apnea. We're going to anticoagulate him. And in 2 months, if he's compliant, we'll cardiovert him.
I think with the first cardioversion, I think most practitioners will allow it to just get treated whenever, the sleep apnea. But for recurrent, before you give someone a second procedure, if you haven't had the sleep apnea fully treated, and, pick a number, at least a couple weeks, maybe a month, maybe a couple months, by that time, in some systems, it takes that long to schedule it anyway, or some systems have a protocol that they have to be fully anticoagulated for at least several weeks. So in that interim, get it done.
Yeah.
And if it were me, that's probably what I would do. I mean, I would want to have, one more week of AFib, or 2 more weeks of AFib, or another month of AFib isn't going to, won't kill me.
Right.
I'd rather have my sleep disorder breathing treated and then shock me again, if it was a recurrent. And we do have some literature on that with the radiofrequency ablation. In our group here, that if you've had one ablation and then you have undiagnosed sleep apnea, that that needs to be treated before you do your second one.
Yeah, I've read a couple of studies that the failure rate obviously after ablation is pretty high in untreated OSA, but it drops down after you had your OSA treated.
That first study, from the Mayo Clinic with electrical cardioversion that predated all the hoopla about radiofrequency ablation, but that study was only done with like 80 patients,
right?
And they showed us significant maintenance of sinus rhythm if their sleep apnea was treated.
This is not a sleep related, or this is not a sleep question, but is there any is there a difference in outcome when you do like just pure like DC cardioversion versus like radiofrequency ablation? Like, is there better results with radiofrequency ablation because you're kind of cutting the track?
Yeah, it depends on when do you assess success.
Oh, okay.
So some people come in for radiofrequency ablation in sinus rhythm. Some come in AFib, and vice versa. So, they may come in sinus rhythm, but they may leave in AFib, because they induce AFib with some of these therapies, and vice versa. So it's complicated. And then also people get cardioverted. They may successfully cardiovert to sinus rhythm, but they cannot maintain sinus rhythm for a long time. Some go back into AFib even before they leave the hospital.
I see that.
Yeah. I mean, we
get them because we do OBS on the floor for a night after an ablation. And so you'll see them on rounds in the morning and they're back in
AFib. And it's, and then usually the electrophysiologist kind of hangs their head and then they poison them with a bunch of medicine before they go home.
That's sad Snoopy music.
Yeah.
Wah, 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 wah.
And that's why they like to do them in sinus rhythm.
Right.
And then what they do is if they're in AFib at the end of the procedure, shock them before they get out to the floor.
Gotcha.
No, it's
trade secrets.
Yeah. Yeah.
Everyone else's favorite arrhythmia, PVCs.
Oh boy.
So
yes,
what do we do with PVCs?
So PVCs are common even in, young, healthy people without heart disease. And so I'm sure you all see PVCs and PACs and, you report them. I think it's helpful to report them. I think it's also helpful to report whether or not they occur with an event, whether it's an apneic event or hypoxia or hypopnea, maybe. I think when you start to, in PVCs in particular, our colleagues here have shown that not all PVCs are benign. So if you quantify PVCs and you can associate the PVCs causing a tachymyopathy, that raises a red flag. So it turns out if you have more than 7 PVCs a minute, that can lead to, say, 10,000 PVCs in a day. And, if you average that out. So, I have not seen this on our sleep study reports here, people quantifying them. And, I think that's a little above and beyond, although there may be software.
The new proprietary calculator you're developing on the side.
Yeah.
No, I haven't done that yet.
Yeah, there is no. I have not seen a sleep study. We should do this now. We should figure out a way. To get,
I think the software, and I don't want to talk about the names of the companies or whatever, but some of the company has software for the EKG portion, but it's an added price to the. And I don't think our lab here had, when it was purchased, added that. So
I will count after talking to you about this. If I do see a lot of PVCs, I'll count to see if I see more than 7 in a minute.
That's abnormal.
And I'll usually refer, and I'll write in my note.
I think that's easy to remember. I don't do that, but that makes sense.
And then I refer to cardiology. Now,
and get a Holter, because
I will start doing now, because I was not doing that before.
Our Holters and our Holters, and I think most Holters, and Holter was a person, remember.
Wait, are you being sorry?
Did you know that?
No,
yeah,
I just thought it was like
no, it was Dr. Holter. Yeah, it wasn't a Holter. That's a holster.
Yeah,
that's for your gun.
I was thinking halter, for horses, but
no, it was a person.
Really?
At any rate,
I thought it was just a different name. Yeah.
Most Holter programs will quantify the number of PVCs.
Right. Because it gives you a PVC burden. I've read the report. It's because it gives you a PVC
So
burden.
a PVC burden less than 1%, nobody gets bent out of shape. And especially by definition, if they're asleep, they're asymptomatic. So we just don't even treat them.
Yes, asymptomatic.
But the second they
don't you want to wake them up and ask them though? Because that's what they do.
I don't.
And then page John at 4 in.
Joking. I interrupted your flow. I'm sorry.
I do not want to wake them up. No, but if they're having a lot of PVCs during the day, that's a bigger deal. But I think for the general population and those listening to this that are not practitioners, the most PVCs and PACs are benign. And I think we should still remember that.
And PACs, is there a burden there we should be concerned about?
We don't have a number for that.
Okay.
And then I guess the next, so bigeminy or trigeminy, now that is definitely going to be more than 7 a minute.
Yeah. I mean, so
those count just the same?
Absolutely.
Okay.
Absolutely.
Good to ask.
Yeah. I don't know. I always I get reports and it's like, you'll see a PVC and then 3 beats later it'll be another PVC. And then someone's like, 1 episode of bigeminy or trigeminy. I'm like, I don't know if I'm really going to call that trigeminy. Yeah. It's like, I need to see this sustained pattern over. Is there a definition on like the time frame for it that something needs to be called for one of these, bi, tri, quadrigeminy things that
I think you would probably have to have a series of them, like 2 or 3 in a row.
Okay. That's what
and it has to be a pattern.
Right.
Mm-hmm.
But I think, the more I practice, I just think of, mild, moderate, and severe, small, medium, large, whatever. And if you have a small number of PVCs or rare I think most of your reports do say rare PVCs or frequent PVCs or very frequent PVCs. That triggers to me further workup. Mm-hmm. Can I tell you what I look at a lot now on sleep studies?
Sure. Would love to know. What number really impresses me and helps me counsel the patient on the importance of treatment is the nadir O2 saturation. Really? I'm surprised.
I've read, and I'll get I don't mean to cut you off, but I've read that that it's actually the ODI, which is more associated with cardiovascular disease.
I've heard that.
What's OD?
The oxygen desaturation. So
index. It's an index.
So the amount of events that are associated with oxygen desaturation, because we can have events that are not associated with oxygen desaturation. Now, are those really causing any cardiovascular effect? Because there's not, they're not really associated with any hypoxemia.
Yeah.
Then are they really cardiologically relevant?
Yeah.
So it's really the OD, and that kind of gets to what you were saying. So what do you tell your patient, or how do you sell that to your?
You just kind of came to that conclusion because you noticed like an association there.
I just noticed that that's more severe sleep apnea.
That makes sense. I mean, if we think that the hypoxia is what's arrhythmogenic, not the obstruction itself.
That's correct.
And people get this misconnect actually when they're looking at sleep studies, because when we read a sleep study, the hypoxia usually occurs about 5 to 10 seconds after the event. But what they don't realize, and even full attendings don't realize, is that's all pulse transit time for the hypoxia to get from the heart to the finger. So it's actually occurring.
Right.
It's at the same time.
Yeah, it's actually, in sight 2 or whatever.
It's part of the same thing occurs in the cath lab when you're doing primary angioplasty on someone who has an acute myocardial infarction. You'll see the vessel close. Like if you're doing an intervention and something goes wrong and the vessel closes, well, the vessel closes before you see ST elevation. So it doesn't mean that it's not important, right? Just like
right.
The pulse transit time is a little different.
I mean, one of the things is that I get where we talk about AHI or oxygen nadir is that I run into is the quality of the study. Did the patient sleep on their side? Was oxygen present? Like sometimes you'll get people with a falsely low apnea hypopnea index, but it's REM predominant, like you're talking about. Right. And so I've had patients who've gotten the message, you don't have sleep apnea, you're fine, but they still feel crappy. And I get this kind of workup, and I'm like, no, you have REM predominant sleep apnea, or the study was 90% on your side and you slept 10 minutes on your back and it was the worst case I've ever seen. And so this we have this kind of serial box number for everybody. Yeah. To define them, it doesn't
just like a cardiologist, treats a patient for heart failure, but their EF is normal, right? I mean, that's the bang for the buck for getting a sleep medicine consultation.
Right, that's true. You're right,
and that has to be explained by a sleep medicine expert, not the person who ordered the test. And a lot, unfortunately, I think a lot of my patients are sort of in that category where, they need expert consultation, and I think it increases compliance. Do you think you guys get better compliance with your patients than say?
Personally, I do.
There you go.
I have phenomenal compliance. I see. No, I mean, I don't know. I look at like people that everyone's non-compliant on CPAP. I would say the majority of my patients are compliant on CPAP. Like, I don't know. There's not many.
90%.
I can't judge you. I don't think mine are that high, but there's a bias.
You're a very different population.
That's a different population.
Yeah. I would say maybe not 9. I would say upwards. I would say 80%. I can count on my hand both of them. The number of patients that I've had give up on PAP therapy.
Mm-hmm. I think and you've tried the wheelhouse.
But I think we have the ability to. I think there's I think the biggest issue is mask fit.
Of course. And
then there's pressure tolerance.
Yep.
And then there's claustrophobia. I think the one that is the most difficult to treat is claustrophobia, because there's some psychological issue. And we have CPAP desensitization for that, which is a clinic that's run by behavioral sleep medicine. And it works.
Liz does the mask.
Dr. Conroy.
Okay.
Yeah. And at Brighton, or where we are, I'm there mostly, or there occasionally, we have a CPAP troubleshooting clinic that is run by one of our nurses and one of our respiratory therapists. And that's been really helpful for getting those mask fit pressure intolerance issues dealt with. The VA has great RTs.
I think one of the biggest barriers in the private sector is probably most of them are disconnected. Your practice is disconnected from the DME. I have an on-site DME.
Yeah, that's a big issue.
I walk them down the hallway. That's right. We communicate.
Let's look at this mask. Let's look at this one.
The system has to change to allow that, because when you can't have this fractured medical system that the patient's already sick. They're at your office. You know what they need. Now you have to drive across town to go get a machine because we can't have it in the same building because it's illegal. It's
because we're gonna
make a dime. Yeah.
Yeah. So the Nader O2 sat is, I think, really.
Yeah. Getting back to that. Yeah.
Really, really potent number. Plus, I usually tell a patient, if you take a young, healthy person and you put your hand over your mouth and nose, if you have normal lungs, it's really hard to get your oxygen saturation below 90%.
Yeah. Isn't it amazing though? Like with these sleep studies, 30 seconds of an apnea and they dropped, to the 80s.
Well, yeah. This is also interesting to do with that cardiological. So when I was a resident, one of the, we always used to say, oh, it's demand ischemia. Demand ischemia. Yeah. And we're like, oh, no big deal. It's demand ischemia. And the cardiologist came back and he's like, it's not normal.
No, it's still not normal.
Yeah,
right. Exactly.
It's not an MI, but like, it's not, you shouldn't be able to shouldn't be able to have like a trophy.
Why do you think that? Because I used to do this demo or a lecture where I would put a pulse ox on and hold my breath till I nearly passed out, 2 or 3 minutes.
Exactly.
And the sats didn't drop below 90. Right. So why is it that I have people that are there? We have an echo. It's normal. We put them to sleep and it's like, boom, boom, boom. DSAT's 85, 85, 85, back up, back and forth. Why? What's going on that I'm missing there?
You have to talk to a pulmonologist. I'm not a pulmonologist. Okay,
I'm just curious.
Intrinsic lung disease.
Because I had for my lecture, I had some, there's an oxygen shift. The oxygen curve shifts due to the hypoxia and the acidosis, but
I'm guessing IPF. That's my guess.
I think it has something to do with the oxygen dissociation curve switching over, but it also suggests that there's some underlying illness there as far as
absolutely
compromised cardiopulmonary circuit. Because it's just I don't understand exactly why these people are already. I had some sort of wackadoodle explanation for my lecture, but I didn't know if that's something you've ever wondered about.
I think they have restrictive lung. I mean, I just think their weight restricts their.
That's the Pickwickian.
Would you say obese patient?
Well, no, you're looking at a sleep study, and you see the guy go from 95 to 85 just because there's a hypopnea or there's an apnea for 30 seconds. Whereas if they're awake, they can hold their breath for 2 minutes and you're fine.
But have we done that in those patients? Can you take them while awake and make them hold their breath for 30 seconds?
Well, I would like to, but that's a kind of an experimentation.
I know. But wouldn't that be great?
Anybody's grandpa got sleep apnea?
Yeah. I mean, and make them hold their breath
as a part of a test, just to see as a.
So, but that's what I tell patients, just in a real simple, because I don't try to explain what an AHI is to a person. Right. But if I see their O2 sat is 82%, I look at them and I open my eyes to them and I say, listen, buddy, you've got rip-roaring sleep apnea.
That's actually a really good communication tool because people understand that. They
Absolutely. They understand because you can buy a home O2 monitor.
Yeah. They don't get the apnea hypopnea index because I have to then tell them what apnea is, which I do, but.
Or swimmers. A lot of people say, have you ever swam a full length under the pool just to kind of see how long you can go? Like you said, a good, young, healthy person doesn't drop their O2 sat from holding their breath that long.
Yeah.
So I think it's a pretty potent number, and you can show them and you can tell them, that's why you feel lousy.
Yeah.
You feel lousy because your O2 sat's going down that low and you're not getting restorative sleep. And
That's good because the subspecialist doesn't have the time to go into the HI and explain all that. But the O2 sat is something they can understand. It's quick. They understand it.
Everybody did.
Yeah, they just had it done. They know what those numbers are supposed to be.
We as sleep practitioners focus so much on the numbers that we might kind of lose the big picture sometimes.
Yeah.
Because this is what we do.
Yeah.
So it's actually good to get your take on it.
Yeah.
And it's worked. I mean, I've convinced some people to actually go, and then I tell them, you got to go back and see Dr. Dutt.
Mm-hmm. Yeah.
You got to,
But what you're getting at is how complex it is in that communication with the patient of why they need to do it. It's not just snoring,
Right. No, I know. You're not doing it just to not snore at night.
So any other questions?
We'll get some more, but
we didn't cover half of, I think, what we,
again,
because I definitely want to talk to you about CHF. I want to talk to you about pulmonary hypertension.
Part two.
Yeah.
Part
so
two.
we're gonna have to do this over again. Not this one specifically, but we'll have to have you back again.
Be great. This was exciting. This is really great opportunity to sit down and talk about a topic that I really like, and it's been great.
All right.
Thank you for coming in.
Yeah, thanks for coming in. All right, guys, we'll be back next month with another episode.